All right, let's go ahead and begin. So hello, welcome to the Primary Care First. Congratulations on your acceptance webinar. My name is Brittany Wiley with the Primary Care First Technical Assistance Team. Before we get started, I want to address a few housekeeping items. I want to remind everyone that this session will be recorded and both the recording and slides will be made available to you. At this time, if you would like to download the slides, please go to the top left hand of your screen, then go to File, Save As, Document, and then you are able to save the PDF file of the slides. So we have team members who will monitor the Q&A box and are standing by to answer your questions. The Q&A box is located on the right side of your screen. At this time, if you are not able to see the Q&A box, look at the top right of your screen and make sure that your Q&A icon is highlighted blue. As time permits, we will answer some of your questions at the end of the webinar. During the presentation, we have muted all attendee lines to avoid distractions. Again, please utilize the Q&A box to ask questions. Imagine we're taking this session in a big conference room together. We are all in here participating in a learning community. We're very grateful and humbled by all of you taking the time to join us today. Now I'm going to turn it over to my colleague, Gabrielle Schechter, Primary Care First co-lead for the Centers for Medicare and Medicaid Innovation. Gabrielle, the virtual floor is yours.
All right, thanks so much, Brittany, and thank you all so much for joining today. I'm Gabrielle Schechter, and as Brittany mentioned, I'm the Primary Care First co-lead here at the CMS Innovation Center, and we really just wanted to congratulate you on your acceptance, and that's a lot of why we're here today. You're pioneers of primary care payment reform, and we reviewed your application, and you exhibited to us here at CMS that you're eligible and prepared to join this exciting new model, and so we look forward to learning alongside you. But, you know, it's been a long time since we last spoke with you, and a lot in the world has changed, and the healthcare landscape has changed since you submitted your application in January. And so today's event is really intended to be a brief checkpoint with us, between you and us, and you'll hear directly from some of the Primary Care First leadership. And just to give you a little lay of the land about how our session will go today, we'll talk about some next steps and resources that will be available in the coming weeks. You can use the chat feature to engage with other people who've been accepted into the model, and also please feel free, as Brittany mentioned, to send in your questions. And though we're not going to be able to get to all of them today, we want to know what's on your mind, because that really helps us plan the next set of events and get a pulse on how things are going for you. So I now have the pleasure to turn it over to Dr. Michael Lip, who is really instrumental in developing the Primary Care First model. He's CMMI's Chief Medical Officer, and we've asked him to share with you how he's thinking about Primary Care First as a clinician and healthcare leader. So, Michael, I will turn it over to you.
Great. Thank you, Gabrielle. So I want to second Gabrielle in welcoming you and congratulating you on your acceptance into the Primary Care First model. And obviously, this model was developed before the COVID pandemic, but really the timing could not be more critical given the need to really empower and strengthen our primary care infrastructure, which is more important now than ever. So throughout the pandemic, we've heard many stories about the heroic efforts that practices have taken to care for their patients during this difficult time. And this has included things like reorganizing the way they deliver care, reorganizing their staffing and operations, as well as the way that they engage with their patients. We've also heard that some patients, given the pandemic, have been avoiding necessary care, and that these advanced primary care practices are really uniquely positioned to proactively identify and reach out to these patients, which really underscores the importance of primary care, as well as the patient-provider relationship. So now I'd like to highlight 4 critical features of the Primary Care First model. So 1, this model provides stable revenue. The prospective nature of the population-based payment should make practices less susceptible to the fee-for-service shocks like we've seen during this pandemic. And for many, this shock came on top of baseline primary care revenue that's often lower than their specialist peers. The second is a structure where revenues increase with higher levels of disease burden. And what this does is allow a path away from fee-for-service structure and offer higher payments for practices that care for sicker populations. And this reflects both the time and resources needed to care for those patients with more advanced illness, but also acknowledges the opportunity to improve care for these beneficiaries. The third is asymmetric upside for improving outcomes. And this incentive structure allows providers to customize the type of care they provide to improve these outcomes, really in a way that meets the needs of their particular patient population. And this may include altering the method, location, frequency of patient interactions. It may also allow providers to focus on other important areas like improving access to care, focusing on social determinants of health, or social isolation. So finally, what this partial capitation structure does is allows providers the flexibility to really practice the way that they want to practice. And this can include rearranging your schedule to focus on activities that really enable you to deliver the best care and not only be tied to activities that maximize fee-for-service revenue. So I want to thank you again, congratulate you on your acceptance into the model. We hope that you will take part in helping strengthen primary care for our beneficiaries. And I'll turn it back to Gabrielle.
Thanks, Michael. That was really well said. So hi, everyone. It's Gabrielle again. I'm also joined by Nicholas Minter, who's the director of the Division of Advanced Primary Care. And that is the division of the Innovation Center that houses both the Primary Care First model and the Comprehensive Primary Care Plus model. And Nick will be reviewing the Primary Care First financial model briefly and describe some of the changes we've made in response to the public health emergency. And then I'll pick it back up to talk about some next steps. So without further ado, I will turn it over to you, Nick.
Thank you very much, Gabrielle. As Michael discussed, well, first off, I should say, I'm going to, as Gabrielle said, I will take us through a few slides just to touch on the payment model again, knowing that that is something folks are thinking about quite a bit in light of COVID-19, and want to sort of note how we have adapted to address that as well. But first I want to say, as Michael discussed, we are thrilled to be embarking on this test to transform the way primary care is delivered and valued in Medicare and beyond alongside you all. To level set for those of you who haven't read the request for applications closely since you submitted your application many months ago, the goal of the model is to enhance the doctor-patient relationship to allow practices to shift away from fee-for-service and allocate resources to those patients that are most in need, and also to reduce administrative burden and reward practices for achieving improved health outcomes and quality. The model aligns with the CMS Innovation Center's goal to improve healthcare quality, reduce the cost of care, or ideally achieve both of these goals simultaneously. And if at the end of the 5- or 6-year test period, given that we've talked about 2 cohorts that each will have 5 years apiece, this model is proven successful, it can be expanded to the rest of the Medicare program. So you all are playing an incredibly important role in determining the future of primary care. The right column talks a bit about some of the features that Michael touched on in his intro. This is a 5-year model aimed at allowing practices to use more flexibility than fee-for-service allows to treat the patient most in need without being confined by the need to generate claims. PCF is also working with other payers to align incentives across insurers that practices deal with on a day-to-day basis, and we are aiming to really reduce that misalignment over time. Some of the other features are outlined here, but I think Michael did a really great job touching on these, so I won't reiterate. Thank you very much, Gabrielle. So I did want to note PCF has 3 different components that participants applied to participate in previously. And I wanted to go over those here and then provide some clarification going forward in terms of what we're going to be focusing on today and what we'll be focusing on in the future. The first component is the PCF only component. This is for advanced primary care practices that provide longitudinal care for their patients. The second component is the SIP-only component, and that's for practices that want to focus on addressing the needs of seriously ill beneficiaries who are not currently receiving coordinated care at the practice. And they would continue that care until those patients are able to transition to a longitudinal setting or an otherwise appropriate venue. And finally, the third option or component, if you will, is what we call the hybrid component, and that's for practices that seek to participate in both PCF and SIP components simultaneously. Just as a reminder, the acceptance letters that you received provide acceptance for the PCF-only component of the model and the PCF portion of the hybrid component. The SIP component has been delayed until April, and further information about practice eligibility for that part of the model will be issued soon. So just a quick reminder of the general payment apparatus for primary care first. And I should note up front that this will be a high-level overview that will make one or two new points. We do have scheduled, and Gabrielle will go over this a little bit later in the presentation, office hours to go over some of the more intricate payment details. And so if you don't find those covered here, please note that we have plenty of time in the future scheduled to discuss those. That being said, primary care first, the payment model really centers on two overarching payment components. First, what we call the total primary care payment, which consists of a professional population-based payment that is a prospective payment per member or per Benny per month that is risk adjusted and paid to enable practices to stratify care the way that their population needs. That is not contingent upon claim generation. It is completely based on attribution of patients to practices through the services that they already provide their Medicare beneficiaries. That is coupled with what we call a flat primary care visit fee. The flat primary care visit fee, which as we've mentioned before, is $40.82 before other geographic and location-specific adjustments. That fee is intended to make sure that we are providing additional support to face-to-face or in-person care when necessary. The flat primary care visit fee, just wrapping up here, is meant to provide that additional support when care needs to happen in person. Those two components combined are the total primary care payment, and they are structured to be roughly across the practice equivalent to fee-for-service revenue. The second overarching component is the performance-based adjustment. And this is, on top of the fact that we are paying prospectively, we think the PBA is a really important component of the model because it provides the ability for practices to receive additional revenue based on the value that they are representing to the healthcare system by improving quality and reducing the cost of care by lowering unnecessary hospital utilization and other costs depending on the practice and the type of patients that they're treating. So as you see here, it provides the opportunity for practices to increase their revenue by up to 50% based on their prior performance on one of two utilization metrics, as long as they are also performing well on quality. We won't go into too much more detail there, but as I think you all remember, there is the amount of the bonus here is dependent upon how a practice in the model compares against the national benchmark, but more importantly, regional practices both inside and outside the model. And we also want to acknowledge and will reward practices for improvement over time on their own benchmark. The one change that I want to acknowledge from the request for applications that you have read previously is in order to make sure that we are evaluating practice performance based on their performance in the model and that their performance is not being unduly influenced by factors that were outside of the practice's control, such as COVID-19, we are delaying payment of the first performance-based adjustment by 3 quarters so that the first payment that will be adjusted by the PBA is Q2 of 2022. Prior to this, we would have been basing some of the performance on quarters that begin in Q2 of 2020, and we want to make sure, again, that we are evaluating practices based on the performance that they could control in terms of utilization. The current structure will pay practices for their performance in the model starting with Q1 of 2021, and will factor every quarter's performance going forward, but because of the need to allow 4 quarters to pass, that means the first payment will be issued in Q2 of 2022. Again, our objective is to make sure that practices are getting a fair shake here and that their payment in the model and exposure, so to speak, is not unduly influenced by factors outside of their control, in this case, the public health emergency. There's more detail about this in your welcome packet, but wanted to make sure that we talked about that very briefly here. And the final slide here is an example that I'm not going to go over in much detail, but we thought it was important to include in this packet an example or a reminder, if you will, of how the actual payment to practices once the PBA is in effect will work. So what you see here in the first column, the total primary care payment column, is an example practice that is a Group 1 practice that receives $28 per Benny per month, and the calculation that sort of helps arrive at their quarterly, what we call PBP payment, the associated flat visit fee, and that equals the total primary care payment. This particular practice performs at the top of their percentile and so receives a 50% increase. And then in the final column for total Medicare payments, you can see what they would have gotten without the PBA, what the PBA contributes, and what the total potential is for this practice in the model should they perform in the top decile of practices in their region. Again, there will be more detail about these calculations in a future webinar, but also in the payment methodology paper that will be released in the coming days for you all to look through as well. So for that reason, I wanted to make sure we noted this, but we will talk about it in more detail in the future. And with that, I'll turn it back over to Gabrielle.
Thanks so much, Nick. So now let's talk about how to sign up and how to learn more. So in the email that you got on Tuesday, you received the following links. There is the participation agreement, and this is the guiding document that governs your participation in the model with CMS. So it explains the requirements, important model elements like attribution and payment, quality, and care delivery. We've also included instructions for how to make sure to correctly complete the participation agreement, and you sign through an e-signature, but we included those instructions to help avoid too much back and forth with our help desk, and so that what you submit is good to go. Just note that this has to be signed by an individual who has the authority to legally bind your practice. That's an important note. You asked for it, and so we made sure to include some tentative projections to inform your modeling of participation in the model. And so that the practice projections include the number of attributed beneficiaries, your projected practice risk group, as well as geographic adjustment. And we included a document that explains what these mean and how they were calculated. We also included a list of payers that have submitted to partner with CMS in support of the practices in Primary Care First. And those payers have proposed some aligned models for payment and quality measurement and data sharing. But if you have questions about payers' own aligned programs, we recommend that you contact your plan representatives directly. They'll be able to give you the best answers about how they're thinking and designing their aligned model. We've also included a memo that outlines the changes in the performance-based adjustment policy that Nick went over, but puts it in writing for you and also to share with your colleagues. And finally, that email on Tuesday also included a document that summarizes the 2021 quality measure set and health IT requirements. So that's what's currently available to you in that comprehensive email that we gave you on Tuesday. What's coming up and what you can expect over the coming weeks is the Primary Care First Payment and Attribution Methodologies paper. That's actually going to be released next week. I know it's really on top of everyone's mind, and people are anxious to see it. And that will offer details on our approaches for calculating payments and assigning Medicare beneficiaries to your practice. Also, to assist you in completing your participation agreement, we'll be releasing a video tutorial that walks through the participation agreement, and that's to supplement the written document that we shared with you on Tuesday that I mentioned. And then once you've signed your participation agreement, you're going to receive a number of materials to help you get onboarded to our data feedback tool for information on your Medicare beneficiaries, the practice portal, which is the central hub for participation in the model. You'll also get other guidance around practice details and requirements, and the things like the Innovation Payment Contractor portal, which is important for payments. But right now, the focus is for sure signing your participation agreement and getting your questions answered so that you can do so. We also have a few events that are coming up. So next Wednesday, we're going to host an office hour that reviews the clinical quality measures and health IT requirements, and that's to supplement that document that I mentioned that we shared this week. And we encourage you to share the invitation for and registration information for that event with those in your practice who are involved in quality reporting, health IT and EHR decisions, that kind of thing. The following Wednesday on September 16th, we'll host a webinar where we're going to walk through many of the payment elements in greater detail. As Nick mentioned, we did that very briefly today. And that is to supplement and support your understanding of the payment and attribution methodology paper. So we encourage you for that event to share the registration info with people in your practice who are more oriented towards practice administration and business and finance. So that will be, I think, a helpful webinar, especially taking a look at some of the questions you've submitted so far today. And just a note, if you can't make these events, no worries, we'll be emailing out links to recordings. So just note that. And once you've signed your participation agreement at the end of September, we're going to host a series of events to get you onboarded and ready to participate beginning in January. So we've just listed a few of those upcoming events. The Welcome to Primary Care First component webinar, where we'll be running through some more features of the model. That's on October 7th. We'll host an office hour on October 14th on payment, attribution, and practice management. So some of the nuts and bolts of that. Okay, so what's next, and what are the next steps to participate? So as now we've mentioned a couple times, next week we're going to be encouraging you to review the payment and attributions methodology paper that'll be released, review and sign the participation agreement, return it to Primary Care First Support by September 25th. And then once you've completed the participation agreement, we will send you enrollment information and an enrollment packet that's due by October 8th. Okay, so that sort of concludes the majority of the presentation, but a couple important points and resources available to you. The Primary Care First Support team, they're a fabulous resource. You can email them, pcf@telligent.com, or call the phone number listed there. They are available and will answer your questions, particularly around your specific practice circumstances. Please be sure to include in the subject line of your email, just for ease of processing, your practice ID. That was included in the email that you got on Tuesday. So I think we have a couple minutes for questions, and I will first kick it off and circle back to Dr. Lip and ask him, you know, as we're concluding in practices, if you were kind of in practice's shoes right now as they're assessing this opportunity, you know, why would you participate if you were them?
Yeah, Gabrielle, thank you. That's a great question. You know, from my perspective, I mean, I think what we've seen with the pandemic is really how fragile our fee-for-service structure is, both from a response to a pandemic like this, but also the way our fee-for-service system is structured in kind of undervaluing often primary care in the way that it's delivered. And so I would look at this model as a way both to unshackle from the fee-for-service structure, to deliver the care that you want to deliver, and to have the right incentive structure to that's aligned with the outcomes that you want for your patients, but also to give you the stability from a practice standpoint to withstand future shocks, and also have a stronger financial footing from a primary care standpoint.
That's great. Thank you. All right. I think, Nick, you've gotten a couple questions that you'd like to answer for folks.
Yes, that's correct. Sorry, I was trying to get off mute. No, there are a lot of questions, and we will go over some of them now, but just to note, there will be other opportunities, and there is also, you know, PCF support available for questions we can't get to today. But I wanted to answer some of the questions that seem to be asked commonly in the chat. One of the ones that has come up a few times, and I know is also a question during the application process, has to do with the handling of chronic care management codes. Chronic care management codes have been priced into the population-based payment, and similar to our other primary care model, CPC Plus, as a result, we do not reimburse those as part of primary care first, which is to say that, you know, we actually are building in the revenue that we anticipate practices would receive automatically and without the need to, you know, to file paperwork or get sign off from patients on a monthly basis. And so, you know, I think that's a good clarification that we want to make sure practices understand. But the PBP and the flat visit fee are meant to be equivalent to fee-for-service, inclusive of those CCM payments. There have been a couple questions about the availability of information, whether or not final payment details will be available before the participant agreement or the PA is signed. And I just want to confirm for everyone on the line here that yes, our plan is in the coming days, and that means, you know, less than 10, so to speak, for the payment methodology paper to be made available to all participants. And that is decently in advance of when you would need to sign the participation agreement or that deadline. So there should be plenty of time for you to go over those details, ask questions, either in the upcoming office hours or on an individual basis. But yes, we certainly will want to make sure that you all have time to look over all of the payment methodology details before making any commitment, because of how important that is. Another question was asked regarding when practices will start to receive the population-based payment. For practices that return their participation agreement, as well as all other necessary financial documentation to permit payment in the model, we plan on making those payments for the first quarter of 2021. So that would be, and I will say I won't commit to the exact date and time because that's a little bit more precise than I'm comfortable getting at the moment, but as close to the beginning of the 2021 year, we would anticipate making a payment for the first 3 months of the year, that quarter in 2021. So you would get that prospectively, which of course is the intent of the model. There's a good question here about how leakage can be calculated by practices given the information you all have now. And I think this is an important question for 2 reasons. One, the payment methodology paper will provide more details on how CMS is calculating leakage, or the amount of primary care services that are being provided outside of the participants' walls for attributed patients. But also important to note, we are not calculating leakage for participants until they have spent a year in the model. We think this is an important point that practices should consider when thinking about their participation. We want to give practices time to establish the strong relationships we believe a population-based payment and the payment model in general for primary care first facilitates. And so in order to do that, we are going to pay practices the full PBP unaffected by any leakage calculation for the first year in the model. That way, we have provided sufficient support, we believe, for practices to establish those strong relationships before reducing any of the population-based payment for the amount of services that CMS is paying for outside of the participants' walls, so to speak. So appreciate that question because it's an important detail, I think, that is easily overlooked. And then one other question that came up that I do want to note, there's a question about when practices will receive additional details about the specific risk score that they've been assigned. And my understanding is preliminary sort of risk scores went out with the welcome packet. Those are preliminary because they are based on attribution from your application data. Generally speaking, CMS will reevaluate the risk score data in November of this year based on more up-to-date data once practices have become participants, and then we will issue final risk scores and more information about how we arrived at those scores at that point in time. And with that, I want to yield the floor to Gabrielle, who I think also has a couple questions she wanted to follow up on.
Great, thanks, Nick. So one question was, I know that some of you may have submitted applications for multiple practices, and some of those practices may not have been accepted into the model, and so you're wondering if there's an appeals process. And while there's not an appeals process, those decisions are final. We do encourage you to continue to stay tuned for future primary care first updates, and you can do so through the web page on the CMS website, or subscribing to the Primary Care First listserv, where we'll be providing, programmatic updates over time. We also have some questions about practices that are kind of rethinking their interest in the seriously ill population component, and whether they could sign the participation agreement just for the Primary Care First component, and then decide not to move forward with SIP, and that's definitely fine. Your participation is voluntary. Whatever we encourage you to sort of make choices that are best for your organization. If you are choosing to withdraw your application from the seriously ill population component of Primary Care First, then please do let our support know. So that email address you see on the screen, pcf@telegen.com, just let them know that that's sort of the decision that you're making, and that's perfectly fine. There was also a question about, there's some of you who, I see your names, I recognize you, you're CPC Plus alums, and you're wondering whether there's going to be, care delivery reporting and other requirements similar to that in Primary Care First. So you'll note that in your participation agreement, there are some broad care delivery activities that you'll be embarking on, but we're really encouraging significant innovation in those areas and beyond, really with the goal of reducing acute hospital utilization and improving outcomes for your patients. And kind of with that philosophy also comes some reporting, but reduced reporting for sure from CPC Plus. So you'll only be reporting, at first we'll do an initial survey with very kind of broad questions that hopefully you'll be able to answer pretty easily. And then from there, it'll just be an annual reporting cycle. And so that's hopefully kind of relieved any anxiety around that for those of you who may be coming from CPC Plus and have that experience. I think I will turn it back over to Nick, who has another question to answer.
Yeah, one other question that I thought would be helpful to answer now, because it's also come up a number of times in the Q&A, has to do with how often the risk group will change, whether or not it can change in the middle of the year or is only going to be changing before the turn of a calendar or performance year in the model. And the answer to that question is that we will reassess what the average risk score for a practice is, and therefore the appropriate population-based payment, because there are 4 different groupings, that practices can fall into, and there are different population-based payments for each of those groups. We will assess that in the fourth quarter before the following calendar year, and it is at that time that a practice's risk group can change. We are doing that to maintain sufficient stability in terms of payment and revenue for the practice throughout a given amount of time, the calendar year in this case. And so for planning purposes, but also to make sure that there is sort of sufficient claims history to justify a change in revenue over time. So we want to make sure there's some stability there, but we will sort of permit those changes because we understand the patient population changes over time. We'll be doing that at the end of the calendar year. There's also been one other question that I think is a really good one to ask is the role of other payers in PCF. We see primary care first as a multi-payer model. We have set very stringent boundaries for our payer partners to come in and align with the payment model that we are practicing in primary care first. And for the first year, we have a good cohort of payers who are doing that. I will also note that what has been a tumultuous time for practices has also been a time of uncertainty for payers as well. And so because of that, CMS is going to continue recruiting and working with payers to align over time their payment models. And we are hearing increasingly that payers are very interested in providing stable forms of reimbursement, value-based payment, even things that look a lot like the population-based payments that we are testing in primary care first. And so we are committed to continuing to work with payers and bolstering the number of payers that will be partnering with our practices going forward throughout 2021 and onward throughout the performance period of the model. I know that there are a lot of other questions. I also know that we are 10 minutes over, and so I want to hand it back over to Gabrielle to see if there are any final thoughts before we wrap up here.
I think that we covered a lot of ground today, and I know that a lot of you have stayed on and stayed with us, and you have a lot of questions that remain. And so we definitely encourage you to reach out to this primary care first mailbox at pcf@telegen.com. Just a note, I think I got a question in about kind of the role of Telegen. So even though the model is launched and run through the CMS Innovation Center, we do have some support through organizations, but they have expertise and coordinate closely with CMS in support of the model. And so though the email address is at telegen.com, they really are speaking for and answering your questions for CMS. They're just sort of contracted to support us. So just to clarify, those answers that you do get through pcf@telegen.com are legitimate, and they are, you should certainly reach out to them. But all of the people who spoke with you today are CMS staff. So just to clarify, I know antenna go up sometimes around these things, so I appreciate the caution. But I don't want to leave us on that note. I just want to thank you all so much for your time. Thank you all so much for, as I mentioned up top, being pioneers in primary care payment reform. We're really, truly excited to partner with you and learn alongside you in primary care first, and we're here for you. We really want to answer your questions and ensure that primary care first is a good fit for your organization. So we look forward to connecting with you next week and the week after as you're continuing to reflect on this opportunity, and we will touch base with you then. So thank you all so much for your time, and I will conclude today's session. Thank you.